Reactive attachment disorder. Reactive attachment disorder as a trauma and stressor related condition of early childhood causes by social neglect or maltreatment. Affected children have difficulty forming emotional attachments to others, show a decreased ability to experience positive emotion, cannot seek or accept physical emotional closeness, and may react violently when held, cuddled, or comfort. Diagnostic criteria. A consistent pattern of inhibited emotionally withdrawn behavior toward adult caregivers. The child rarely or minimally seeks comfort when distressed. The child rarely or minimally responds to comfort when distressed. A persistent social and emotional disturbance characterized minimal social and emotional responsiveness to others, limited positive effect, episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with adult caregivers. The child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following. Social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults. Repeated changes of primary caregivers that limit opportunities to form stable attachments. Frequent changes in foster care. Rearing in unusual settings that severely limit opportunities to form selective attachments. Institution with high child-to-caregiver ratios. The caring criterion C is presumed to be responsible for the disturbed behavior in criterion A. The disturbance in criterion A given following the lack of adequate care in criterion C. The criteria are not met for autism spectrum disorder. The disturbance is evident before age 5 years. The child has developmental age of at least 9 months. For specified, persistent, the disorder has been present for more than 12 months. Specify current severity. Reactive attachment disorder is specified as severe when the child exhibits all symptoms of the disorder with each symptoms manifesting at relatively high levels. We also have diagnostic features. Reactive attachment disorder is characterized by a pattern of markedly disturbed and developmentally inappropriate attachment behaviors in which a child rarely or minimally turns preferentially to an attachment figure for comfort, support, protection, and nurturance. The essential feature is absent or gross underdeveloped attachment between the child and putative caregiving adults. A diagnostic of reactive attachment disorder should not be made in children who are developmentally unable to form selective attachments. For this reason, the child must have a developmental age of at least 9 months. Associated features. Because of the shared etiological association with social neglect, reactive attachment disorder often occurs with developmental delays, especially in delays in cognition and language. Prevalence. Reactive attachment disorder is unknown, but the disorder is seen relatively rarely in clinical settings. The disorder has been found in young children exposed to severe neglect before being placed in foster care or raised in institutions. The disorder is uncommon, usually occurring in less than 10% of neglected children, even in cases of severe neglect. Development and course. Conditions of social neglect are often present in the first months of life when children diagnosed with reactive attachment disorder, even before the disorder is diagnosed. The clinical features of the disorder manifest in a similar fashion between the ages of 9 months and 5 years. The signs of absent to minimal attachment behaviors is associated with emotionally abnormal. Behaviors are evident in children throughout this age range, although differing cognitive and motor abilities may affect how these behaviors are exposed. Recent prognostic factors. Environmental. Serious social neglect is a diagnostic requirement for reactive attachment disorder, and it's also the only known risk factor for the disorder. However, the majority of severely neglected children do not develop the disorder. Prognosis for children with the disorder appears to depend on the quality of caregiving environment following serious neglect.
Disinhibited social engagement disorder. Disinhibited social engagement disorder, or DSED, is a behavioral disorder that occurs in young children. It is an attachment disorder that makes it hard for children to form an emotional bond with others. But you may notice that children with DSED can easily talk to strangers and mingle with them. Usually, ito ay disorder sa mga kabataan. Sila yung kadalasang madaling kumausap ng ibang tao, hindi na nag-a-adjust para makipag-usap sa iba, hindi na iniisip ng isang bata kung sino ba ito or may connection ba ito sa kanila para kausapin or lapitan ito. Madalas, hindi na sila nagdadalawang isip kung safe ba sila sa isang tao or hindi. They have this, there is no stranger danger. For diagnostic criteria, Letter A, a pattern of behavior in which a child actively approaches and interacts with an unfamiliar adults and exhibits at least two of the following. First is reduced or absent reticence in approaching and interacting with with unfamiliar adults. Second is overly familiar verbal or physical behavior. Third is diminished or absent checking back with adult caregiver after venturing away, even in unfamiliar settings. Last is willingness to go off with an unfamiliar adult with minimal or no hesitation. For letter B criteria, we have the behaviors in criterion A are not limited to impulsivity, but include socially disinhibited behavior. For letter C, the child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following. First is social neglect or deprivation in the form of persistent lack of having basic emotional needs for support, stimulation, and affection met by caregiving adults. Second is repeated changes of primary caregivers that limit opportunities to form stable attachments. Example, frequent changes in foster care. Third is rearing in unusual settings that severely limit opportunities to form selective attachments. Example, institutions with high child-to-caregiver ratios. The criterion C is presumed to be responsible for the disturbed behavior in criterion A. Letter E, the child has a developmental age of at least 9 months. Diagnostic features. The essential feature of disinhibited social engagement disorder is a pattern of behavior that involves culturally inappropriate, overly familiar behavior with relative strangers. Madalas ito sa mga bata na neglected o lumaki sa foster care or mga institusyon. Sa mga high-risk population naman ay mayroon lamang na 20% ang ganitong kondisyon. Ang mga ganitong kondisyon ay hindi agad napapansin dahil usually nag-o-occur lamang ito habang bata pa sila na kadalasan ay nagbabago naman at naagapan kapag tumanda kaya't hindi ito na-observe agad at naikukonsulta. Risk and prognostic factors. Environmental. Serious social neglect is a diagnostic requirement for disinhibited social engagement disorder and is also the only known risk factor for the disorder. Course modifiers. Caregiving quality seems to moderate the course of disinhibited social engagement disorder. Functional consequences of disinhibited social engagement disorder significantly impairs young children's abilities to relate interpersonally to adults and peers. Katulad ng kanina, maaaring mabilis silang kumausap o sumama sa ibang tao pero hindi sila magkakaroon o mahihirapan sila bumuo ng relationship dito. Ito naman ulit yung mga symptoms. So, merong no fear of adults, no shyness when meeting new people. Pwede rin yung overly friendly or talkative to strangers. Next naman ay merong hugging or cuddling with unknown adults. And last is, does not look to parents for permission to approach stranger. Differential diagnosis, tulad naman ng mga may ADHD, ang mga may DSED. Katulad ng mga ADHD, madalas impulsive din ang mga ito. Para sa mga ganitong disorder ay meron naman tayong behavioral therapies. They are teaching what's safe and not safe, or why would you not approach adults who are not familiar with you.
Post-traumatic stress disorder, also called PTSD, is a mental health condition triggered by any horrifying incident experience of being a witness to events like sexual assault, child abuse, warfare, conflicts or riots, death of a loved one, or even a natural disaster. People with PTSD extremely negative thoughts and feelings that remind them in the past. Exposure to death, a direct experience of death, cause intense stress, cause of dysfunction, or even impairment of everyday lives. Presence of one or more intrusive symptoms. They can control it. Someone is haunted by what happened to them in the past, and the haunting nature comes out in distressing memories, distressing dreams, or nightmares. Avoidance of stimuli associated with the trauma. They don't want to talk about it. They don't want anything to remind them of it. Negative alterations to mood and cognition. Persistent blame of self or others who are stuck in anger or stuck in guilt or stuck in fear. Detachment from others, our expectations about the world, himself, or others. For example, the world is dangerous, I'm bad, no one can be. Alterations in arousal and reactivity. Anger outbursts, and irritable behavior. It can also be hard to live with someone with PTSD. We sometimes see reckless or self-destructive behavior after sexual assault, especially when it happens to very young children. We will see reckless sexual behavior. Depersonalization is a mental health condition that was formerly known as depersonalization disorder. It can make you feel as if your feelings are not real. It is believed to be influenced by trauma and stress, especially if experienced at a young age growing up with domestic trouble. Children to zone out as escape, and that continues as they get older along with that some drugs. Diagnosis feature exposure to traumatic events, intrusion, avoidance, negative changes in feelings and mood, changes of arousal or reactivity last longer than 1 month. Associated features supporting diagnosis, developmental regression for long repeated and severe traumatic events, childhood abuse, torture. Prevalence at age of 75 years is 8.7%, flu rates higher for those in professionals, more common in adults than older ones, and in females for the males. Development and course. When children or teenagers experience trauma, they develop PTSD. Certain types of trauma are more likely to lead to PTSD. Risk and prognostic. Three traumatic factors. It manifests itself as the trauma and stress that we experience. Very traumatic factors can include the duration of severity of trauma experienced and the perception that the trauma has ended. Post-trauma can include access to needed resources, social support, specific cognitive patterns, and physical activity. Culture-related diagnostic issues. Culture may differ across cultural groups. People with PTSD typically struggle with, and because these are cultural level, norms, values, and assumptions, we are all affected by them. Gender-related diagnostic issues. Women are slightly less likely to experience trauma than men. The most common trauma for women is sexual assault or child sexual abuse. About 1 in 3 women will experience a sexual assault in their lifetime. Rates of sexual assault are higher for women than men. Women are also more likely to be neglected or abused in childhood, to experience domestic violence, or to have loved one suddenly die. Suicide risk. Going through a trauma may increase a person's suicide risk. For example, there is evidence that childhood abuse and sexual trauma may increase a person's suicide risk. Among veterans, some studies have found that combat trauma is related to suicide, while other studies have not.
What is acute stress disorder? According to the American Psychiatric Association, acute stress disorder is characterized by the development of symptoms persisting from 3 days to 1 month after an exposure to or experience of a traumatic event. Traumatic event may include natural disaster or threatened death of a loved one, physical assault, sexual assault, serious accidents, and mass casualty events. Diagnostic criteria. To meet the criteria from acute stress disorder, they must experience 1 or more symptoms in the following 5 categories. The first one is intrusion symptoms. Intrusion symptoms refers to recurrent intrusive memories of the traumatic events. These memories can be experienced as dreams, nightmares, flashbacks, prolonged emotional distress, or in children, repetitive play or reenactment play. The second one is negative mood. Negative mood described as unable to experience positive emotion or to feel happiness. Negative mood may appear chronically unhappy and depressed. Dissociative symptoms, an altered sense of the reality of one's surrounding or oneself. For example is you're seeing yourself from another's perspective. Or isa pa to yung mga taong nakakaranas ng matinding takot. The next is avoidance symptoms. Avoidance symptoms, efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic events. You need to say, conscious and unconscious efforts to avoid remembering the event or people or places na nag-trigger sa memories nila or nagpapaalala sa nangyari sa kanila. Arousal symptoms, sleep disturbance. For example is yung mga nahihirapan matulog or yung mga kulang sa tulog. The next one is irritable behavior and angry outbursts. Ito yung mga mabilis mairita or yung magagalitin. Hypervigilance, problems with concentration, exaggerated startle response. Diagnostic features. The clinical presentation of acute stress disorder may vary by individual but typically involves an anxiety response that includes some form of re-experiencing of or reactivity to the traumatic event. This may include intrusion symptoms, negative mood, dissociative symptoms, avoidance symptoms, and arousal symptoms. In some individuals, they can predominate, although these individuals typically will also display strong emotional or psychological reactivity in response to traumatic reminders. In other individuals naman, nakakaramdam sila ng matinding galit in which reactivity is characterized by irritable or passively aggressive responses. In diagnostic features for PTSD, note that acute stress disorder criterion B4 compromises PTSD criterion B4 and B5. It said na the individuals with acute stress disorder may have a persistent inability to feel positive emotion. For example is nakakaramdam sila ng kasiyahan, satisfaction, or emotional associated with intimacy, tenderness, and sexuality. But they can also experience negative emotions such as fear, sadness, anger, guilt, or shame. Alteration in awareness can include despersonalization, a detached sense of oneself. Meaning, ito yung naobserbahan mo yung sarili mo sa labas ng yung katawan. Or you have a sense that things around you aren't real or both. The full symptoms picture must last for at least 3 days after the traumatic event pero hindi dapat tatagal sa 1 month. Associated features. Individuals with acute stress disorder commonly engage in catastrophic or extremely negative thoughts about their role in the traumatic event. For example is, the individual with acute stress disorder may feel excessively guilty about not having prevented the traumatic event or about not adapting to the experience more successfully. Also, common for individuals with acute stress disorder ang pagkakaroon ng panic attacks or yung pagkaka-experience ng panic attack in the initial month after traumatic exposure that may trigger by traumatic reminders. Additional, individuals with acute stress disorder may display impulsive behavior. For example, nito yung mga reckless driver o yung mga irrational mag-isip or magdesisyon or gamble excessively. Post-concussive symptoms. Ano nga ba yung mga sintomas nito? Ito yung mga nararamdaman mo na pananakit ng ulo, dizziness, sensitive to light or sounds, pagiging irritable mo, or pagkakawala mo ng concentration, which occur frequently following mild traumatic brain injury, are also frequently seen in individuals with acute stress disorder. Post-concussive symptoms are equally common in brain-injured and non-brain injured population. They frequently seen sa mga taong merong acute stress disorder. Prevalence. The prevalence of acute stress disorder is recently trauma-exposed population within 1 month of traumatic exposure. According to the nature of the event and the context in which it is assessed, in research conducted in Australia, the United Kingdom, and the United States, acute stress disorder was identified in less 20% of cases following traumatic events that not involve interpersonal assault. Yung for example is yung motor vehicle accidents, mild TBI, or yung severe burns, and industrial accidents. Ang higher rates naman nito is yung mga usually found yung interpersonal traumatic such as assault, rape, development, and curse. Acute stress disorder cannot be diagnosed until 3 days after traumatic event, although acute stress disorder may progress to post-traumatic stress disorder after 1 month. The forms of re-experiencing can vary across development. Unlike adults or adolescents, young children may report frightening dreams without content that clearly reflects aspect of the trauma. For example is yung walking in fright in the aftermath of the trauma but being unable to relate the content of the dream to the traumatic event. Risk and prognostic factors, temperamental, a tendency to make catastrophic appraisals of the traumatic experience, often characterized by exaggerated appraisals of future harm, guilt, or hopelessness, is strongly predictive of acute stress disorder. Isa siyang risk factors include prior mental disorder, high levels of negative emotion responses, such as depressed mood and anxiousness, also termed negative affectivity or neuroticism. Environmental. First and foremost, an individual must be exposed to traumatic event to be at risk for acute stress disorder. Ang risk factor niya is yung include a history of prior trauma, genetic and physiological. They called elevated reactivity, as reflected by acoustic startle response. Prior trauma exposure increased the risk for developing acute stress
Adjustment disorder. It is a psychiatric condition due to a stressor that results in emotional or behavioral symptoms. It is also known as situational depression. It's a stressor that is causing their problems. Bale, pag nawala yung stressor na yun, tsaka lang magkakaroon ng improvement sa emotion and behavior nila. Diagnostic criteria. First, it occurs within 3 months of the onset of the stressor. Second, the symptoms or behaviors are clinically significant as evidence. Third, stress-related disturbance does not meet the criteria for another mental disorder. What this means is that we have to try to exclude other mental disorders that may be causing this patient's emotional and behavioral symptoms. We also have to check if the patient had a pre-existing mental disorder in the first place. Meron na ba silang symptoms na ganito before the stressor na minor lang? Or siguro ayaw lang nila na ma-diagnose? Importante na magkaroon ng timeline. 4. Symptoms do not represent normal bereavement. Importante ito kasi pwede natin i-diagnose yung patient with adjustment disorder after the patient loses someone. Kasi they may have emotional and behavioral symptoms that significantly lead to impairment in their life and if never pa silang nagkaroon ng mental disorder before. But we can't, if this is part of a normal bereavement process, if the patient generally lost a loved one in a recent amount of time. This could just be a normal bereavement. Diagnostic features. Stressor may be a single event or there may be a multiple stressor. Single stressor, example is such as injury. Pag multiple stressor naman, examples are patient stresses in their school activities and unpaid bills, etc. Pag recurrent naman, it is something seasonal. Pag developmental events, ito yung mga milestones. Example, getting married, having a baby. So, yung prevalence of adjustment disorder fall between 11 to 18% of those who attend primary care. One of the risks and prognostic factor is environment. Since nakadepende yung disadvantage sa life ng mga tao. Kasi if masyadong malaking disadvantage ng isang tao sa buhay, sila yung mga may high rate of stressor at malaki ang increase sa risk nila for adjustment disorder. Next is yung culture-related diagnostic issues. Kailangan isama yung cultural setting ng patient para ma-determine whether maladaptive ba yung adjustment response. Patient with suicidal thoughts or behavior, nakakapag-increase ng risk of suicide attempts and suicide ang adjustment disorder. Functional consequences of adjustment disorder is the person may have trouble with sleep, work, or studying. Differential diagnosis. First is yung major depressive disorder. If yung individual na meet niya yung criteria for major depressive disorder, then yung diagnosis for adjustment disorder is not applicable. Pangalawa is yung post-traumatic stress disorder and acute stress disorder. Para ma-distinguish ang adjustment from these two, ay ang adjustment disorder can be diagnosed immediately and persists up to 6 months, while yung acute stress disorder naman can only occur between 3 days and 1 month exposure to the stressor. And PTSD cannot be diagnosed until at least 1 month since yung occurrence ng traumatic stressor. Pangatlo is yung psychological factors affecting other medical condition. Pang-apat, yung normative stress reaction. Hindi adjustment disorder ang normative stress reaction. For example, yung alteration in mood.
Prolonged grief disorder. There is a diagnostic criteria in prolonged grief disorder. The death, for at least 12 months ago, of a person who was close to the bereaved individuals, 6 months at least for children and adolescents. The development of persistent grief response is characterized by one or both of the following symptoms, which have been present most days to a clinically significant degree. Also, in addition, the symptoms occurred nearly every day for at least the last month. There is a 2 symptoms showing in the set B of a diagnostic criteria. The first one is the intense yearning and longing for the deceased person. The second one is the preoccupation with thoughts or memories of the deceased person. Preoccupation may focus on the circumstances of the death in children and adolescents. Now, according doon sa set C ng diagnostic criteria, since death, meron tayong at least 3 of the following symptoms na presents most days to a clinically significant degree. Meron tayong 8 symptoms in the set C of diagnostic criteria. The first one is identity disruption since the death. Ito yung parang may nafe-feel kang may namatay sa'yo after din mamatay ng taong malapit sa'yo. Sobrang lapit, like father, girlfriend, mother, and such. The second one is marked sense of disbelief about the death. The third one is the avoidance of reminders that the person is dead. Ito yung kahit patay na yung tao, may thoughts pa rin sa'yo na parang hindi ka naniniwala na patay na siya. At iniiwasan mong maalala na patay na yung tao na yun. The fourth one is intense emotional pain. Includes anger, sorrow, and bitterness. The fifth one is difficulty reintegrating into one's relationship and activities after the death. It is like you're having a problem in terms of engaging with friends. At yung huling pangatlo naman ay emotional numbness, feeling that life is meaningless, and intense loneliness as a result of death. Also, the disturbance causes clinically significant distress or impairment in social, occupational, or other important area of functioning. And the duration and severity of the bereavement reaction clearly exceed expected norms for the individual culture and context. But the symptoms are not well explained by another mental disorder, such as major depressive disorder, post-traumatic stress disorder. Thus, it is not attributable to physiological effects of a substance such as medication and alcohol or another medical condition. According to the diagnostic features, prolonged grief disorder represents a prolonged maladaptive grief reactions. It can be diagnosed only after at least 12 months, 6 months for children and adolescents. Although in general, this time frame reliably discriminate normal grief from grief that continues to be severe and impairing. Still, the duration of adaptive grief may vary individually and cross-culturally. Yung condition na ito involves siya sa development ng persistent grief response characterized by intense yearning or longing for the deceased person. Isa sa mga example ay ang frequent crying o ang madalas nating pag-iyak. The symptoms of prolonged grief disorder must result in clinically significant distress or impairment. And although there are variation in how grief can manifest, yung symptoms ng prolonged grief disorder ay pwede pa rin mag-occur sa kahit anong gender at diverse social at sa iba pang mga tao. Now, let's talk about associated features of prolonged grief disorder. Sinasabi rito na ang mga taong may symptoms ng prolonged grief disorder ay madalas nakakaranas ng maladaptive cognition. They diminish future life expectancy and life goals. Most of them, punong-puno sila ng guilt. Somatic complaints commonly accompany the condition. The somatic symptoms may be associated with those that were experienced by the deceased. Also, hallucination about the deceased may occur during normal grief, but common din siya sa mga tao may symptoms ng prolonged grief disorder. They may be associated with disruption of social identity. Meron ding ibang features ang prolonged grief disorder tulad ng bitterness, sorrow, restlessness, blaming other for the death, and decreased sleep quality and quantity. The prevalence of DSM-5 prolonged grief disorder in adult is unknown. Meta-analysis of studies across 4 continents that use different for prolonged grief disorder with at least 6 months duration suggest pooled prevalence of 9.8%. However, there was substantial methodological heterogeneity across studies. It affects prevalence findings. It says that population with elevated exposure to trauma may have higher prevalence rate, meaning Prevalence of prolonged grief presentation may be higher in high-income Western countries than in high upper middle-income Asian countries. However, China have revealed higher rates and substantial variation. Prevalence of persistent complex bereavement disorder among bereaved U.S. youth in the community was estimated at 18%. It is included in DSM-5, Section 3, Condition for Further Study. The next one is development and growth. Symptoms usually begins within the initial month after death. Pwede rin magkaroon ng delay bago pa makita yung buong symptoms or syndromes. Preliminary evidence suggests that curves may be especially prolonged among parents and after the death of their child. Also, meron tayong limited data sa prolonged grief disorder across the lifespan natin. The curse prolonged grief disorder may be complicated by comorbid post-traumatic stress disorder. It is actually more common in situations of bereavement following the violence of their loved one. Older age may be associated with higher risk of developing disorder after the death of their loved one. While children, they may be expressed themselves by playing, by their attitude, they may develop regression, or they may also protest. Young children may experience symptoms in specific ways because of their age. The loss of primary caregiver may be particularly traumatic for them.